Dr. Hudson begins by indicating with a laser or a Sharpie pen where the height of contour is on the free gingival margin of the tooth to receive the gingivoplasty. He then carefully freehands a superficial line on the surface of the gingiva. He then works in more deeply along the line created through the gingival tissue to the underlying enamel. The gingival tissue is then cleanly peeled away with the laser. Refinements are then made to the free gingival margin as needed to establish the height of contour on the distal third of the facial surface of the central incisor. Debris is continually removed with the tip of the laser during this process. Dr. Hudson then scrubs the area with hydrogen peroxide and sprays off any residual tissue with an air-water syringe. The advantages of laser surgery over scalpel surgery are readily apparent. Dr. Hudson will use a scalpel to demonstrate the differences between laser surgery and traditional scalpel surgery. Dr. Hudson will now reintroduce the laser. Immediately, he establishes hemostasis, and that allows him to continue to proceed with a clear field of view. He then proceeds with the laser on the contralateral teeth. Dr. Hudson uses the laser to release the anatomical crowns of the teeth that have heretofore been hidden by excessive gingival tissue. When the laser incision is nearly to the underlying tooth structure, Dr. Hudson prefers to use a periodontal curette to remove the gross amounts of tissue. Dr. Hudson repeats the steps already taken on each tooth to be treated. In the aesthetic zone, Dr. Hudson notes the following 4 keys. 1. Keep in mind not only the height of contour of the free gingival margin of each individual tooth, but the relationship of its margin to its immediate neighbors and to the contralateral tooth. 2. Exposure of the anatomical crowns to the cemento-enamel junction with bilateral symmetry is the clinical endpoint of treatment. 3. At normal operating parameters, the laser will not cause recession, nor will there be rebound. Tissues will appear normal in 7 to 10 days. 4. Monitor with a periodontal probe on each tooth the amount of tissue that may be removed without biologic width violations. For purposes of illustration, it is easy to see how the laser improves the surgical field after initial removal of gross amounts of tissue with a scalpel. Under normal circumstances, a scalpel would not be used during any portion of this rather extensive procedure. But as Dr. Hudson demonstrates again with the laser, this procedure may be completed quickly, comfortably, with precision and efficiency, and with predictable results. Many patients in the typical practice could benefit from this type of laser dentistry in the aesthetic zone.